Hello, everybody. Thank you for joining me for this live webinar. For those of you that are here in person on Wednesday, April 16th for lumbar spinal stenosis clinical considerations. Most of you watching this have been to other webinars, and I've sort of enjoyed this format. It's something people have asked me to do for a number of years. And as I've said on some of the prior ones, it's giving me an opportunity to kind of look at topics that can be effectively communicated in an hour. And so, as always, I'm open to ideas and feedback about what to do for next season. I'll talk to you at the end about the last one before summertime that's happening in June. I'm actually taking May off because I'm traveling to Edmonton, Quebec City, Denmark for the WFC conference in Copenhagen, and then Holland 7 days later. So I'm not really here enough to have one of these in May, but I'm hosting the next one in June with Dr. Asima Kopoulos on chronic pain, but I'll tell you about that a little bit later on. So getting into spinal stenosis for today, this is what we're going to aim to achieve in the next hour or so. As always, if you have questions at the end, I'm happy to stick around and chat. You can put them in the chat, but I don't always look at the chat while I'm actually speaking. So we can park those there for the end, or we can go cameras on and have a discussion if you like. But what we're going to do today is define lumbar spinal stenosis. We're going to talk about the epidemiology and the healthcare impact of this and what it means for our healthcare system, and look at things like the etiology and pathophysiology of what's actually happening to the best of our knowledge and what sort of things are going on there. We actually have some interesting data from our colleague, Dr. Carlo Amendolia, who's done a lot of the research globally on this condition, quite frankly, from a manual therapy perspective, about patient perspectives. Then we'll get into the clinical stuff. How do we assess this? How do we diagnose it? And importantly, how do we effectively differentially diagnose this condition? And then we'll briefly cover management. And part of that will be pointing you to some other resources. Obviously, there are full day, multiple day courses on how to deal with this. So we'll talk about sort of best practices and what's included in clinical guidelines and so on. So, what is lumbar spinal stenosis? The best definition I like is from the clinical practice guideline from our chiropractic research colleague here in Canada, Dr. Andre Boussier, and colleagues in 2021. And in that clinical guideline, they define lumbar spinal stenosis. And when you see LSS throughout the rest of the slides, that's what we're talking about. It's commonly a degenerative process causing the narrowing of the central spinal canal. We'll talk about the differences as we go, but it can also include lateral recesses or the IVF or intervertebral foramen or combination thereof, which progressively compresses the neurovascular structures in the spinal canal or the foramen. Lumbar spinal stenosis can be classified as acquired or congenital, and congenital is normally referred to as developmental now. And it can be both and may be associated with degenerative spondylolisthesis or scoliosis. From an epidemiology perspective, if you don't have a practice now based on elderly patients, I think that's about to shift in the next 10 to 15 years. And if you're a new grad starting out, I would get really good at this stuff because I think we have a lot to offer elderly patients. And I've talked about that in numerous courses and keynotes and things over the years. But lumbar spinal stenosis is pretty common. It's going to affect about 1 in 5 older adults, and that older is considered over 65, but that's sort of the classification where they judge us to be older. And lumbar spinal stenosis is going to increase over time. From a point prevalence perspective, depends where you look. In the literature, it ranges between about 10 and 40%. That is dependent on whether you're looking at the general population compared to primary or secondary care examples. And again, the prevalence kind of increases as patients get older. Interesting correlates in the literature from an epidemiology perspective include things like, 4%. This to me is shocking. If you want to look at preventive measures for these sorts of conditions, I'm speculating, but I don't think exercise ever has a downside, to be honest. but only 4% of lumbar spinal stenosis patients actually meet clinical guideline recommendations for physical activity. To me, that's shocking. And we also know that this condition is associated with an increased prevalence of coronary heart disease and hypertension. As I've mentioned in other courses before, chronic low back pain and lumbar spinal stenosis can, of course, be a cause of chronic low back pain or a contributor to it, is now thought to be sort of a general indicator of poor health and kind of it's known to go along with other chronic health conditions. From a healthcare perspective, we know that low back pain is the leading cause of disability in older patients around the globe. And lumbar spinal stenosis is a leading cause of disability in adults within that low back pain kind of overarching diagnostic bubble. We also know that lumbar spinal stenosis patients have increased walking limitations. That's something we're going to touch on a number of times in comparison to knee or hip osteoarthritis patients. And we'll go through the GLAD data in a few minutes about that. They also show increased functional limitations compared to those with congestive heart failure, that's CHF, chronic obstructive lung disease, or lupus. So the point here is that lumbar spinal stenosis is an incredibly limiting condition from a functional perspective. And often that boils down to something as simple as I can't walk like I used to walk. We also know that lumbar spinal stenosis is responsible for the fastest growth in lumbar fusion surgery in older adults, showing a 15-fold increase in the United States between 2002 and 2007. We're going to touch on the surgical implications of this condition near the end of the talk, with some important work from a chiropractic colleague of ours from the East Coast. This is the James Young. He's a chiropractor who has his PhD now, I believe. As far as I know, he's either at University of Toronto or University of Southern Denmark, or a combination of both, doing postdoc work now. Most of you watching or here now will be familiar with the GLAD program, Good Life with Osteoarthritis Denmark. It's one of the most highly researched exercise programs designed to help people with osteoarthritis of the knee, hip, and low back. And James did, as part of his PhD, a look into the data that they have in terms of the cohort of the GLAD patients that had low back pain. And what they found is that 66% and 75% of the knee and hip OA subjects, respectively, had coexisting low back pain. And we've known this for a number of years. And you see this in your patients all the time. Lumbar spinal stenosis symptoms specifically were present in 11 to 71% of the low back pain patients, but the most frequent symptom that the low back pain patients reported was transient pain or numbness in the lower extremity. So one of the differentiating factors for spinal stenosis is that the symptoms are often primarily or only in the legs, and low back pain may or may not be there, as I'll cover more in a moment. Lumbar spinal stenosis symptoms are also present in up to half of people with hip osteoarthritis and up to 40% of those with knee OA. More specifically, the diagnostic criteria for clinical lumbar spinal stenosis was fulfilled more by patients in the low back pain cohort compared to those in the hip or knee cohorts, but were still less than 10% in each group. So the point here is that these conditions should be easy to differentially diagnose. And ultimately, lumbar spinal stenosis symptoms are frequently reported in those with hip or knee osteoarthritis, but not as often in those who have low back pain. And I think that makes sense from a clinical perspective. So what's actually happening in this condition? What's the etiology and pathophysiology of lumbar spinal stenosis? So I always explain it to patients as, pardon me, as kind of osteoarthritis or arthritic changes in your spine gone wild. And that's, it's degenerative spinal changes that can lead to narrowing of the central spinal canal, the IVF, or the lateral recesses. And this can be a combination of a number of factors, including disc degeneration, bony or soft tissue changes, facet joint degeneration, arthritis or arthrosis, and also ligamentum flavum hypertrophy. That's one sort of radiological finding that doesn't really have a good outcome for a lot of people. If you see that on MRI or on plain X-ray, it's probably pretty bad, but you can see it a bit easier on MRI. And this narrowing of the real estate for the spinal cord and the nerve roots causes compression or maybe even ischemia of the spinal cord or nerve roots itself, or clamping down on the vascular structures. And we'll get into that more in a moment when we talk about neurogenic claudication. Here it is. This is, some people get confused in the terminology with lumbar spinal stenosis versus neurogenic claudication. But if you think of it this way, it's a bit easier. Neurogenic claudication is the main symptom or clinical syndrome, if you want to think of it that way, of lumbar spinal stenosis. So, in order to land on a diagnosis of lumbar spinal stenosis, you have to kind of have the syndrome or the symptom of neurogenic claudication. Our best answer about what happens in neurogenic claudication boils down to two different theories. The first one is ischemia, which results in compression of the microvasculature around the spinal cord and the nerve roots, which causes nerve root ischemia, which leads to symptoms including that leg paresthesia, the leg pain, unilateral or bilateral. We'll cover that in a moment. Weakness, kind of fatigue with walking or activity, and so on. The other pathology that we'll drill down into a little bit more later is venous stasis, which might represent a cardiovascular issue or peripheral arterial disease. And this is where inadequate oxygenation and accumulation of metabolites in the cauda equina occurs because of venous pooling up due to multiple level degenerative changes in the spine itself. And as I said, this may correlate a little more specifically with general cardiovascular disease. This is from the Danish Chiropractors Association. The top two graphics, A and B, are kind of a normal motion segment. And down below in panel C and D, you can see there are a couple of different areas where nerve roots can be bothered as they exit the central canal over to the lateral recess and finally into the intervertebral foramen. And I'll show you that again a little bit later on. One thing that I think is a big strength of our research these days is our tendency and our willingness and our ability to start asking patients about their experience with different conditions, because I think we can glean a lot of useful information about what's important to them and therefore help guide what should be important to us in terms of how we want to manage these conditions and what's important to them. So what do we know about patient perspectives? This is from Dr. Amendolia's group in 2017. And they did semi-structured interviews with 28 patients with lumbar spinal stenosis and just kind of asked them a number of questions about how they felt about it, what they were concerned about, and so on. And what they found out was that the patients were bothered most by pain and discomfort and their inability to walk. And if you can think of it, you know, I think most people as they age should be engaged in daily walking and daily exercise of some form, but walking gets you outside. It's a social activity. It can actually reduce the incidence of low back pain, according to the big randomized trial that I reviewed on my service last year that was published in The Lancet. Walking can be its own intervention. And before I take my sons to school in the morning, I get up and I walk around. I live in a small town just north of Toronto, and it's 3.5 kilometers around the periphery of the town. So I do that every morning, and I see the same groups of people walking, and it's great to see. Groups of elderly people out, four, five, six of them every morning. You wave, good morning, how are you? And that's just kind of really nice to see. So you can imagine how disabling and concerning that is if that ability is taken away from people. The patients in these interviews also reported being impacted by an inability to partake in recreational activities and reduced social interactions. And we know that social interactions and social connectivity are basically predictors of mortality now for elderly people. If they don't have a good social network, a reason to belong, a strong social network, things can start to fall apart pretty quickly, regardless of what other healthcare scenarios are affecting them. The other thing that came out of this study was that significant emotional effects were also frequently reported, and this included depressed mood, sadness, hurt pride, and that's important, needing physical assistance to do things that they used to be able to do easily, social isolation and frustration. And I'll let you guess if any of those things are positive prognostic factors for living a long, healthy life. They're not. But here's the key, I think, to this study, and this is somewhere where something that should govern our patient communication and how we talk about prognosis and what we can do for patients from a treatment and intervention perspective. That is that patients with lumbar spinal stenosis have no expectation of us to cure them. And I think that's important because I think we often put that expectation on ourselves. But they're just hoping for some improvement, and wanting to walk more was a frequently mentioned thing in that survey. Other patient perspectives paper from Lynch and colleagues in 2018, they emerged with three themes, and this was from interviews from participants in a randomized trial, and that they reported an emotional response to lumbar spinal stenosis, a desire for patient education, and a desire for individualized care based on self-management lifestyle changes. Most people who get to this point will eventually develop some understanding that their physicality and their interaction with exercise and their own physical health has something to do with their degenerative process, and that should enable them to empower them to know that they have some ability to change it. This paper also recommended that clinicians should be prepared to deal with some negative emotions here. You know, anyone who has aging parents understands that the conversations that you have with them get a little bit more depressing over time. I mean, time is undefeated, right? So, slow chronic degenerative conditions are tough to deal with. And it's not surprising that patients exhibit and display negative emotions. As clinicians, we should aim to be educators and a resource on this, be clear about our treatment objectives and the ongoing nature of this. This is maintenance care if I've ever seen it, right? Like, you have a chronic degenerative condition. This is not a rib out of place. This is not a thoracic facet irritation that's a 1-2 treatment and done scenario. So we have to consider booster sessions and check-ins, and I think most patients with this condition are quite happy to do that. And I think it's important for us from a clinical perspective to modify our treatment if needed over time, and also to monitor these people from a neurological perspective, uh, because again, these are older patients and we want to be mindful of degenerative neurological changes. So moving on to assessment and diagnosis of lumbar spinal stenosis. This condition in many ways can be challenging due to the symptoms overlapping with other conditions. The important thing for us, and I think a lot of our colleagues as chiropractors still don't understand this fully, is that you don't need imaging to diagnose this condition. This can be a clinical diagnosis. Part of the reason for that is that the clinical correlation between imaging findings and symptomatology, even in lumbar spinal stenosis, is pretty crappy. And that goes for most imaging and most spinal conditions, with a small asterisk, and that is until you get to really severe degenerative changes, those normally correlate a little bit more with the clinical scenario, but it's still not perfect. So, treat the patient, not their picture. And, this is a condition you should suspect in a patient over the age of 50 with leg pain, one or both sides, paresthesia, heaviness, numbness, tingling, kind of feelings in their legs with walking or prolonged standing. This is intermittent claudication. It's just their system's not sort of flushing things out and not functioning properly. And generally, they report being able to walk shorter distances. They'll say things like, I have to take breaks. I never had to do that before. And I think this gives us an efficient outcome to monitor. We'll talk a little bit more about that later. From a symptom perspective, they can present with uni or bilateral buttock, thigh, or calf symptoms. And this is a range of things. You might have to drill down and get them to describe it for you a little more in terms of aching, cramping. Is it painful? Is it numb? Does it feel buzzy, nummy, buzzy kind of thing? Is there a feeling of weakness? Do your legs feel heavy? Does it feel any different when your pants are touching your skin or your socks or your shoes? And are you experiencing any balance issues? They can experience any or all of those symptoms in one or both legs, but it generally happens with prolonged walking or standing. And that is the neurogenic claudication symptom constellation that I mentioned a moment ago. The other next thing you ask them is, how do you obtain relief from this? And what these patients will typically say, and this will point you straight to the diagnosis, is that they're relieved by sitting, flexing their spine, and that's the shopping cart sign I'll show you in a few minutes, or lying down. The important thing for us is that low back pain may or may not be present. I always pause there for a minute. In my experience, these patients typically also have low back pain intermittently, and we know that low back pain is generally a recurring condition for most people. It waxes and wanes. It's episodic. Our job is to manage the episodes, give them tools in between to help them hopefully prevent some episodes. But I can't remember a lumbar stenosis patient in my career that hasn't had at least some history of low back pain. The point here is that if they're having leg symptoms, they don't necessarily have to be having low back pain symptoms at the same time. And again, they may report limited walking capacity. This is the shopping cart sign. Patients will have walking or standing for a length of time provokes their leg symptoms or their back pain or both. And usually, to point us to a diagnosis here, we do need some symptoms in the legs. And do you get relief if you lean forward on something? Or do you feel like, if you lean on a fence or if you lean on a, shopping cart sign is kind of the the term that people use for it, but if they don't use a shopping cart, they won't understand that. So just ask, do you have to lean on a park bench? Do you have to lean on a fence? Do you have to lean on your friend? Do you feel better if you sit down for a few minutes? All of these things, if that increases their comfort, decreases their leg symptomatology, points you in the direction of this diagnosis. From a history perspective, you're going to ask them all these things. This is a Delphi study, and a Delphi study takes a clinical concept and puts it as like a survey to a number of experts in a field. And Tompkins Lane did this for a couple of different aspects of stenosis. We'll cover both of these papers here. But a Delphi study goes through different rounds with number of experts prioritizing statements and things that they think are important. Then it goes to the next round and they decide which are the most important there. And then it gets to a final round. That's kind of the general structure of a Delphi study. So they came up with 7 historical questions that were determined by a world panel of experts to be most relevant for lumbar spinal stenosis. And these are things we've already touched upon. Do you have leg or buttock pain while walking? Do you flex forward or lean on something forwards to relieve your symptoms? Do you feel relief when using a shopping cart or being on a bicycle? If you have an active elderly person with stenosis, they may trend towards using an upright bicycle for their cardiovascular activity versus walking and so on. Again, that flexes the spine a little bit and takes the pressure off. Stenosis patients generally don't like extension. They kind of preferably move into a flexed position. Ask them if they have sensory disturbance while walking. Are there pulses in their foot present and symmetric? I'm not entirely sure why that's a history question. That's more of a physical exam question. You can ask them also about any potential weakness that they're experiencing. And do you have low back pain? Again, recognizing that it's not necessarily, it doesn't necessarily have to be there at the time of diagnosis. From a physical exam perspective, they did a similar process and came up with the following core diagnostic tests. The first is a neurological examination. I'm on board with that. Number 3 is a walking test with gait observation. Totally on board with that too. You want to evaluate their capacity and performance levels while walking. We'll talk more about that later. And then they also add an MRI and CT scan. There's an asterisk there. That's my asterisk. And what I'll say is we don't need that for diagnosis. Not to spoil the punchline, but part of the reason for that is if a lumbar spinal stenosis patient is not responding to conservative care, and what we know is about 1 in 3 don't. So they're going to need to go and see a surgeon because that's also a reasonable treatment option if the patient's not progressing properly. On the way to surgery, the surgeon is going to take an MRI of that patient anyway. So you don't need to, and if they had already had one 6 months ago, they're going to repeat it. So it's just kind of a waste or needless use of healthcare resources. So unless you're worried about a patient having a spinal tumor or something nefarious that you have to rule out via MRI, it's not necessary to do that because if they have to go down the surgical route, they're going to get that anyway. Other additional tests that have been suggested as able to rule out this condition or other conditions include the foot pulses or the ankle brachial index. And the ABI in the box just to the bottom right on your screen there is a systolic blood pressure ratio between the ankle and the brachial arteries. And if the ankle is less than or more than 10% less than the brachial artery in terms of systolic pressure, that's defined as peripheral arterial disease. And we'll talk more about that in a moment. I would suggest that most chiropractors don't spend a lot of time taking an ankle blood pressure. I'm not sure. I may have done that a couple of times in my career, but it's a simple way to look. And if you're comfortable doing it, it can be a useful thing to do. One of the other things that's suggested is to rule out hip involvement. There's a bit of overlap between hip osteoarthritis and lumbar spinal stenosis. And of course, as I talked about in the last couple of webinars on lumbosacral radiculopathy mimics, these conditions can all coexist. The other thing to keep in mind is if there's degeneration gone wrong in the lumbar spine, you have to make sure there isn't degeneration going haywire in the neck also, which can be a lot more severe in terms of potential danger to the patient in terms of spinal cord damage from manual therapy or anything else, quite frankly, and something that needs to be monitored and perhaps sent for a surgical consult if you determine that that's progressing at a rate that's alarming for you. So don't forget about the neck. Someone with severe degeneration in their lumbar spine has every right to have the same pathology happening in their cervical spine. From a physical exam perspective, we have some clinical guideline recommendations. Again, you're looking at patients over 55, 60, 65 years of age for this. A positive 30-second extension test is simply getting them to extend in a standing position to see if you can provoke some of their leg symptomatology. Negative SLR, although I will say in my experience, some lumbar spinal stenosis patients have like semi-positive SLR, something that might mimic nerve root tension. But for us, as a differential diagnostic exercise, most disc herniation patients are a bit younger than 60, 65. So that's one of the differentiating factors. But if something is clamping down on a nerve root from a stenosis perspective, be it in the central canal, lateral recess, or IVF, can't it give you a positive straight leg raise? So I don't know if negative is perfect there, but something to look for. Pain in both legs is certainly points us in the stenosis direction, can also point us to a space occupying lesion or a tumor, and leg pain relieved by sitting, leaning forward, or flexing the spine. The N class is just another research group that does different criteria for diagnosing things, and they also suggested adding the inability to squat due to muscle weakness. In Older and Bolder Chiropractic Care for Healthy Aging, the 8-hour program I produced and presented in person, like middle of COVID, and have as an e-seminar as well, we talked about the chair, sit, stand test and how many times someone can stand up and sit down in a chair in 15 seconds or 12 seconds. And it's a really simple, easy outcome measure to use. And it's something that I think is easy to think about from a stenosis perspective. And it's also a good functional test for elderly people. So if you have severe or progressive spinal stenosis, you may not be able to do a squat at all. So part of that clinically for you can boil down to watching them get in and out of a chair next to your treatment table or on and off your treatment table or in the waiting room or in and out of their car if you see them doing that on the way in and just observing how they move. What about walking capacity versus performance? I've mentioned this a couple of times. The World Health Organization recommends assessing both. Capacity from a definitional perspective means the ability to walk on a single occasion during like a testing controlled environment. In Older and Bolder, I talk more about the self-paced walk test, and you can look that up online as well. Compare that to performance, which is like how many steps are you doing in a day? This is where pedometers are great. This is where smartwatches are great and activity trackers can give us an idea of, and if these patients have had a phone in their pocket or an Apple Watch or a Fitbit on their wrist for 5 years, you have some data to look at. And you can see if their steps per day are going down on average over a 6-month or 1 year period. It's funny, when we were on vacation last week in Mexico with the kids, and my phone starts binging me about my lack of activity and my change in physical activity. And I think whenever that happens to me, I don't go on vacation much, but whenever it does, I'm like, the phone should have a thing where you can say, I'm on vacation, leave me alone. Because I wasn't walking as much every day and doing workouts on the Peloton and stuff. But anyway, so those are the differences between capacity and performance. The ODI, the Oswestry, as you know, if you use it, has a one question about walking capacity, but the evidence suggests the ODI alone is not sufficient to evaluate this parameter and not sufficient alone to evaluate lumbar spinal stenosis. But if you're going to pick an outcome measure, the ODI is not a bad one to use in the lumbar spine. Imaging. As I said earlier, it's not recommended as part of the initial assessment. You can make a clinical diagnosis of lumbar spinal stenosis. It can be used to confirm the diagnosis, but it is not a strong diagnostic tool. A systematic review from 2016 from Bergstaller and colleagues looked at 9 studies, 714 patients, and found, like most imaging studies do, quite frankly, that a number of asymptomatic subjects have signs and symptoms of lumbar spinal stenosis on MRI. These people have no clinical symptoms. Now, As you know, degenerative changes in the spine are a threshold issue. And I've always found it interesting that, patients can have pretty ugly degenerative changes in their spine and have no symptoms at all. And then one day they just do. It's kind of like a disc in some ways. There's no real indication that anything's wrong, and then they bend forward to pick up a pencil and they blow their disc, and all of a sudden they're blaming the pencil. But we know that from imaging studies that a lot of people who are not experiencing current clinical symptoms have some findings on imaging that, if you were to look at that alone, were to suggest that they have a certain condition. The other thing out of that study is that that rose to 1 in 3 patients once you get over the age of 60. So 1 in 3 patients on MRI can have signs and symptoms of lumbar spinal stenosis without actually having clinical symptomatology. The punchline is imaging findings don't always correlate with pain in lumbar spinal stenosis anyway. And as I said earlier, it's always typically ordered if they are to become a surgical candidate down the road. So ordering the MRI typically is not our responsibility from a clinical perspective. If you happen to see imaging of patients, or are looking for a diagnosis, or are worried about a spinal pathology and you do get an MRI, you can look for things like ligamentum flavum hypertrophy, a disc herniation with ligamentum flavum hypertrophy. You can look for severe disc degeneration as well that's not on this chart. But you can see the lower L5S1 disc doesn't look that good on that picture, with some desiccation and disc height reduction there as well, or retrolisthesis with disc extrusion. And some people just have a constellation of things that end up leading to symptomatology. What I will do is remind you here to treat your patient, not your pictures, or not their pictures, right? As always, integrate your physical exam and your history before reviewing or requesting imaging. I always think it's best practice, if a patient comes into you with imaging, to put it to the side and say, we will get to this later. I want to put it together with all the information that we're going to obtain today. And I don't want it to lead me down a path that may be inaccurate or not important. So let's talk first. I want to do my physical exam, then we'll check this and see how things fit together. And from a stenosis perspective, you have to remember most imaging is done. X-rays are done standing most of the time, but MRIs are done supine. Do you think your spinal joint spaces and your disc fluid levels and heights are the same when you're lying down or standing up? They probably aren't. So imaging is static and humans are dynamic. And that's something that we have to remember as a potent limitation to some of these imaging findings. So let's shift into a bit of differential diagnosis. One of them is vascular claudication, and we can refer to this as peripheral arterial disease. And these can certainly mimic spinal stenosis. They can also coexist. You can have two different pathologies leading to the same condition, if that makes sense. The differentiating factor here, and we're going to spend a few minutes on it, is this causes leg pain, which can be exactly the same as lumbar spinal stenosis, triggered by walking, standing, and so on, and it's relieved with rest. They have to stop. That's the differentiating factor. They do not get relief from forward flexion, sitting on a bicycle, sitting on a park bench, leaning on a shopping cart, like a lumbar spinal stenosis patient would. It's a blood flow issue. It's not a mechanical loading issue. It's not a degenerative change pushing on a nerve root issue. It's a blood flow problem. So whatever position they obtain or try to put themselves into is not going to matter. So that's one. We're going to talk more about that in a moment. Hip OA is another one. If you join me for the two-part webinar on musculoskeletal mimics of lumbosacral radiculopathy, we talked at length about hip osteoarthritis. It can also present with buttock, groin, some leg pain, lateral hip pain, and change with weight bearing and so on. So we have to keep that in mind. Trochanteric bursitis can also have lateral hip pain aggravated by lying on that side, but you won't see the relationship to activity in the relief position from flexion with that condition. So let's talk about peripheral arterial disease a little bit more. Both lumbar spinal stenosis and peripheral arterial disease can cause intermittent claudication, this feeling of like heavy legs, nummy, paresthesias in your legs with activity. And this usually happens with walking or prolonged standing. And again, this can be neurogenic, in which case lumbar spinal stenosis is the most common from degenerative changes, or vascular from global cardiovascular disease, or local vascular changes in and around the lumbosacral region. These can also occur, intermittent claudication can also occur with nonspecific low back pain in some cases. So the relief posture and the mechanism of symptom modification can actually assist in your differential diagnosis here. As I said earlier, those with peripheral arterial disease as the reason for their leg symptoms have to stop the activity. Full stop. If you get a lumbar spinal stenosis patient and you get them to lean on a shopping cart, or there's a study I took out of this, I have a longer slide deck on this, and they took patients and put them on a treadmill and did it in two positions, either standing upright or leaning forward on the bar. And lumbar spinal stenosis patients could actually walk way farther leaning forward than they could standing up. That is not the case for peripheral arterial disease patients. So they have to completely stop the activity, whereas lumbar spinal stenosis patients can often keep going if they change their position into a flexed posture, generally speaking. So this is a good little summary slide if you ever want to refresh your memory. Lumbar spinal stenosis patients need to change position in flexion to reduce their symptoms. They generally have symptoms walking downhill because you generally extend your spine a bit if you're walking downhill. If they are cycling on an upright bicycle, or recumbents are about the same. Most people flex a bit on a recumbent, so that might be relieving for them as well. But cycling should be relatively symptom relieving or pain free for them. These patients with stenosis also have neurological symptoms and findings that are more likely, and their ankle brachial index, if you start taking both blood pressures, should be normal. As soon as you see an ankle brachial index going below 0.9 as the ratio, then you're looking at peripheral arterial disease. And again, they need to stop what they're doing to relieve their symptoms. They will have symptoms walking uphill, whereas a lumbar spinal stenosis patient might not because you're kind of leaning forward, flexing forward as you're going up. Cycling will be painful and intolerable for them. Ultimately, it doesn't quite matter what the activity is. They just get clogged up and things don't flow properly and they have to stop. And for these patients, neurological findings are less likely, but you may see, peripheral signs of cardiovascular disease like skin changes, nail changes, that sort of thing. So if you see that in combination with the leg symptoms, peripheral arterial disease might be more reasonable. If we want to start differentiating hip osteoarthritis and lumbar spinal stenosis, this paper I thought was useful from Rainville in 2021. They surveyed 51 musculoskeletal physicians and asked them what symptoms point you towards hip OA, what symptoms point you towards stenosis, and which symptoms do you think can be for both conditions. Hip OA, as I've talked about on prior webinars, and I'll probably do a webinar on hip OA at some point. It's worth a chat. They can have groin pain, knee pain. They generally have reduced pain symptoms with continuous walking versus lumbar spinal stenosis that gets a bit worse with walking. Then they have to change their position or rest. Hip OA patients generally don't like getting in and out of a car, particularly a low car. They may have pain dressing themselves or are symptomatic when reaching for their foot, trying to put on their socks or shoes, for example. They might have a visible limp, and of course, they'll have a normally characteristic kind of capsular restriction in their range of motion. Signs and symptoms from the survey of MSK clinicians favoring lumbar spinal stenosis include pain or symptoms below the knee, leg tingling or numbness. That's often not a direct result of hip OA. Some pain in both legs and neurological findings. So hip OA itself doesn't often lend itself to having neurological findings, of course, and could be both. This is the overlap part. Reduce pain pushing a shopping cart. So if you lean forward in a shopping cart and start walking, you can actually unload part of your hip joint. So that makes sense. Back pain can go along with both, as I've mentioned and talked about before. Lumbar pain and hip OA go hand in hand in a lot of cases. The other thing they reported that could be both included weakness or heaviness in the leg, buttock pain, or poor balance. So just thought that was a helpful paper to add. What about lateral recess stenosis? So that's kind of like same pathology, different part of the spine. So, these things can often occur together. The lateral recess is the area I'll show you diagrammatically in a moment, just outside the central canal before you get to the IVF. And this can occur when the spinal nerve is compressed just before that IVF area. Bilateral stenosis occurs when the spinal nerve has already exited the IVF, and isolated lateral stenosis can happen. And that sort of mimics like disc herniation symptoms in an elderly person. So they may have reflex changes, neurological symptoms, pain, heaviness, paresthesia, all the things you see with lumbar spinal stenosis, but it might actually just be on one side. As typical, central canal lumbar spinal stenosis is often both legs or some degree of symptomatology in both legs. Far lateral stenosis is the degenerative change affecting kind of one or two nerve roots on one side, and that's what might result in unilateral symptoms. So if you look in the middle part of this section, area D is the central canal of the spinal cord. C is technically the lateral recess, which is confusing to people sometimes. This is before you get to the foramen, and then the extraforaminal space or far lateral stenosis area is the A region there. And I like to add this one too, just to give you a bit of a representation of, people's nerve roots can vary by size. People's IVFs can vary in terms of size as well. But just to remind you that there are a lot of areas there where mechanical compression can and do happen in our patients. So what do we do about this? What do we do about stenosis if we think it's a problem? Well, this has been a huge evolution in the literature, particularly since I've been doing research reviews and courses and things. And our Canadian chiropractors and chiropractors around the world, quite frankly, have been leading the way in terms of research on conservative care, manual therapy, rehabilitation for this condition. Because when I was a student, about 20 years ago, the standard of care for lumbar spinal stenosis was generally a surgical consult. They thought that was kind of the only way to management or to manage this condition. And then what they discovered via randomized trials and then systematic reviews and other observational research is that manual therapy and rehabilitation should be primary first care options. And we've now landed as, you know, do you need extra training to effectively manage lumbar spinal stenosis patients? I think it helps. It's kind of like concussion. We're perfectly capable of managing concussion, but I think you need to take a course or some sort of program to update you on the literature. That's why I keep current concussion things out there. And Carlo and his group provide great training on the management of lumbar spinal stenosis. Now, I recommend doing it. I don't have a program like that, and I'll talk more about it in a moment. But the shift in the evolution has been from surgical management into conservative management. And that's been a really great thing to see for us. Here's Carlos' program. His company's called Spine Mobility. I don't get anything for pumping his tires here, but I have a lot of respect for the work he's done. And one of my reviewers, Josh Plenner, if you listen to or read our research reviews, he's a really good reviewer for me for a number of years. He's currently working on his PhD with Carlo looking at more stenosis stuff, and he's also doing work in degenerative cervical myelopathy, which is really important. But what Carlo's group has done over the last 10 years is scientifically investigate the best combination of treatments for lumbar spinal stenosis. And this is us as a profession, and specifically us in Canada, contributing to a worldwide shift in clinical guidelines and best practices for this condition. And I've put a lot of all of his references in the back, but his program basically includes coaching and behavioral change, targeted manual therapy, specific exercise and strength training, and body repositioning and self-monitoring, all with the goal of reducing pain and improving walking tolerance. And you don't know what you don't measure, and his program focuses a lot on that as well. And as I said earlier, walking is an effective outcome measure. And of course, he's published his results. He shows pretty good follow-up at 3.5 years. He has another study coming out soon, as far as I know, on a bigger data set of these patients. I think, big data, activity trackers, and EHR technology are going to allow us to get a really good picture of what we can do for lumbar spinal stenosis patients going forward. So I think this area of research, which is already very supportive of what we do, will only get better for us over time. They published a paper in BMJ Open in 2022 on non-operative treatment for lumbar spinal stenosis with neurogenic claudication. You'll see Josh Plenner's the third author there. And they concluded that there's moderate quality evidence that a multimodal approach, which includes manual therapy and exercise with or without education, is an effective treatment, and the epidural steroids are not effective in the management of stenosis with neurogenic claudication. This evidence still lives in kind of the lower grade stuff. We don't have the 5 million person big data set that we're getting for some other topics that I've spoken about before. We don't have the 500 patients per group randomized trials, but the data that we do have is very supportive and consistent, pointing us in this direction. I also like to point out that, BMJ Open, that's the British Medical Journal. It's still one of the most highly read journals on the planet. This is their open access journal that, as chiropractors, we can be proud of the fact that we are regularly publishing in this journal now. And I think, you know, 20, 30 years ago, when I was a student or before that, they wouldn't have accepted papers from chiropractors at all. So I think we should be really proud of that. I'll point out my friend and colleagues here, Kent Stuber's on this paper as well, Carol Kenslier, classmate of mine. I'll talk about her treatment algorithm for this in a moment via the CCGI. You'll see James Young on there. I mentioned his PhD project before. And Mike Schneider, chiropractor who's heading up the new chiropractic program at the University of Pittsburgh. In case you didn't know, that's probably the biggest story in our profession in the last year. First publicly funded university in the United States to integrate chiropractic program in on their campus. Canadian Chiropractic Guideline Initiative, most of you are probably familiar with. I know we have some people on the call here with us now or watching later who are from other countries. I'm on the board of the Canadian Chiropractic Guideline Initiative. The lead of this project is my friend and colleague, Dr. Carol Canceliere, who is now considered probably the most educated chiropractor on the planet. She has her PhD in clinical epidemiology. She has an MBA and some other certifications. She's a genius, a good friend of mine, and she puts together evidence-based care pathways for patients with different conditions and has one for lumbar spinal stenosis. So this is a care pathway with a clinician summary and also a patient handout, and I've QR coded this for you in a moment. But from a history perspective, it's similar to what we've talked about already. Rule out risk factors and major structural pathology. Be comfortable with the fact that there isn't cancer, infection, fracture, inflammatory arthritis, or cauda equina syndrome. Identify other comorbidities that may need concurrent management, like neck pain, headache, depression or anxiety, diabetes, or cardiovascular disease. That highlights a point with elderly patients is we're not often the only healthcare provider, nor should we be. So the teamwork makes the dream work for elderly patients, and care coordination is going to become more important as we get more and more elderly people through the primary care healthcare system. Also, we have to address prognostic factors that may delay recovery, and depression and anxiety aren't good prognostic factors for anything. And as we mentioned earlier from patient interview data, depression and anxiety are kind of common about this condition. Other things like passive coping, job dissatisfaction, high self-reported disability, disputed compensation claims, or somatization are also negative prognostic factors for this condition and every other condition. From a physical exam perspective, assess the level of concern regarding major structural or other pathologies. You do a thorough neuro exam, perhaps a peripheral vascular exam too, if you're thinking they might have peripheral arterial disease. Just a side note there. If you suspect they have peripheral arterial disease, when I used to present on this in person, our colleagues would always accurately ask me, like, what do we do about that? Well, I think for what it's worth, that if they know they have it and they're being managed by a doctor and a cardiologist, super duper. If not, that's a referral back to the family doctor. Like, hi, do you notice that their ankle brachial index is 0.75, that they have skin changes, that their nails aren't very healthy on their right leg versus their left leg, et cetera, et cetera. That needs to be assessed and managed because that could be tied into some other major cardiovascular problem closer to the heart or an abdominal aortic aneurysm or something else that might be clamping down on their blood flow. So always be mindful of that. If you're the first one to identify PAD, that's a referral back to the family doctor and or cardiologist. Assess for neurological signs and then walking capacity and ability like we looked at before. I'm not going to go through all of this. This is in Carol's outline about what we should do for lumbar spinal stenosis. From an evidence-based perspective on what we do have, it's multimodal care, which is education and advice, manual therapy, and in the middle of the screen, that's a combination of manipulation, mobilization, and soft tissue therapy as indicated or as desired by the patient, for example, and home-based exercise. Post-op rehab includes cognitive behavioral therapy. We can also include things like needle acupuncture, and maybe SNRIs or TCAs as from a medication perspective. What's most important to me here, apart from the fact that we're first-line care and recommended care, is what is not recommended, and that includes NSAIDs, methylcobalamin, paracetamol, which is the medical name for acetaminophen or Tylenol, calcitonin, opioids, muscle relaxants, pregabalin, gabapentin, epidural steroid injections, not recommended for this condition based on the evidence that we have. If you want to use different outcomes, they recommend in Carroll's care pathway the Swiss spinal stenosis or Zurich claudication questionnaire, the short form 12, which is still paid. You need to pay to access that, as far as I know. The Oswestry low back pain disability questionnaire, ODI. And if you want to assess sleep, there's an outcome measure called the Pittsburgh Sleep Quality Index, which actually has some good parametric research behind it, and it's recommended for use in lumbar spinal stenosis as an ongoing outcome measure. There's the QR code for Carol's pathway. She has other ones too, by the way. And I think a lot of chiropractors in Canada and around the world don't know about this. They're all free. They're all up to date on in terms of the evidence and its best practice recommendations. And Carol does a great job at it. It includes patient assessment, history, differentials, treatment, prognosis, and follow-up. So I highly encourage you to check that out. And as a reminder, I will send you these slides as a PDF after, so you will have this QR code in your inbox in the next couple of days. So to summarize treatment before we wrap up, try manual therapy, manipulation, MOBs. People ask about flexion distraction. I think it's a good idea. We don't have much evidence about it for the specific treatment of lumbar spinal stenosis, but the biomechanics of it makes sense to me. If that's if you understand what I mean, if that makes sense. Other things from a conservative multimodal care approach that we are to try first include patient education. I would add reassurance to that, understand their emotional state, address any depression, anxiety things, and that can be a referral to another healthcare provider if need be. Make sure they're exercising, acupuncture for pain control, and cognitive behavioral therapy post-operatively. The avoid section includes NSAIDs. Isn't that interesting? They don't work for lumbar spinal stenosis. They might take the pain down a bit. Tylenol specifically, the evidence for Tylenol is just horrendous for pain conditions. Um, you know, someone needs to tell their marketing department that, but man, the evidence has been terrible for Tylenol the last few years. Other things like opioids shouldn't be a first-line treatment for anything related to musculoskeletal care. Muscle relaxants don't work for spinal stenosis either. Anti-seizure neuropathic meds like the gabapentin, pregabalin, benzodiazepines, and so on, and also epidural steroid injections aren't effective. Epidural steroid injections, as a side note, can be effective for one level, single level lumbosacral radiculopathy if they get the right level. It'll give you a rehab window. It'll give them some pain relief. So in contrast, they don't seem to work very well for stenosis because I think stenosis is typically a multi-level problem. So if you inject a steroid into one level, no wonder it doesn't help them very much. From a prognosis perspective, as I said, the aim of treatment here is to improve or stabilize the patient versus cure them. 1/3 to 1/2 of patients with mild to moderate symptoms improve over time, and that can be a reduction in pain and an improvement in their walking capability. 60% of them don't worsen or they get better. Like sometimes these people just kind of have these symptomatology levels indefinitely. And honestly, if you can give them some relief positions, give them some relief with manual therapy, they're happy with that. And you're helping them avoid major spinal surgery, just for the record. But we do know that regardless of care, about 1 in 3 lumbar spinal stenosis patients get worse. And I think that's something that's important to understand as a clinician because you don't have to blame yourself for that. This is just the nature of this condition. And we also know that very few patients experience rapid deterioration of their symptoms. It's not like it goes from 0 to hero like a lumbar disc herniation or something like that. It's often just a slow burn over time. That's why booster and follow-up sessions are important. That's why monitoring neurological status is important. That's why using some outcome like walking ability and ODI, Pittsburgh Sleep Index, if that's affecting them, can be a useful thing to kind of track over time. And as I said a bit earlier, it's a very common reason for spinal surgery. In fact, the most common reason for spinal surgery over the age of 65. Regarding surgery, we have also contributed to this area of research. So I just told you that 1 out of 3 of these patients that you see will have to eventually at least consult with a surgeon and or have surgery. So what do we know about the preoperative factors that predict postoperative trajectories and pain and disability after surgery for this condition? I'll point you out there to our colleague from Eastern Canada, Dr. Jeff Hebert. He used to actually write reviews for me back in the day and has done some important work in this area with a multidisciplinary research group published in Spine in 2020. What they found, and the first highlight tells us that for pain and disability after operation, Those who participate in regular exercise have better outcomes compared to those that do not. So our job is to keep these patients moving prior to surgery and especially after surgery, and they will have better outcomes. This is a condition where I think prehabilitation is more important than almost any other condition. I mean, it's important for all surgeries, but if you can get an elderly person maintaining their activity levels or increasing their activity levels, fitness capability, and capacity before a surgery, their outcomes will always be better. The second highlight's important too. Patients who received preoperative chiropractic or physiotherapy treatment were less likely to report a poor overall outcome. So the point here is, in my opinion, even if they are still progressively getting a little bit worse and need to go down the surgical route, constant physical therapy rehabilitation will help improve outcomes after the surgery. So we still have a role to play, even if they are going down the surgical route. And just to be clear, the surgical route, it doesn't have perfect outcomes. The patients have to understand and often have a choice to make. Like, do I want to do this? Because it's major surgery. They're opening your spine, they're shaving things away. They might have to put mechanical hardware in there to stabilize the area. And we know from the data that we have on this that patients with lumbar stenosis often experience a rapid symptom relief, and that's great, but should still expect to experience mild to moderate pain and disability 5 years later. Think about that. You get your ACL replaced, you get your Achilles tendon repaired, you get a rotator cuff repair. You're going to be better eventually. It's going to be 6 months, a year of rehab or trouble, but spinal stenosis surgery often provides rapid relief of symptoms, but we still have to be on these patients, making sure they're moving, making sure we're helping them from manual therapy and rehab perspective, because the long-term outcomes aren't as great as we would hope, and some pain and disability is probably going to persist. As we wrap up here, my job is to look at papers and topics and how they fit into whether it affects our patients or your practice or policy at a government or insurance company level. I think this is a practice issue for the most part. So, to summarize, what we know is that lumbar spinal stenosis will increase in prevalence as the population ages. Chiropractors can play a pivotal role in the diagnosis and management of this condition. Conservative multimodal care from a chiropractor, a physiotherapist, I prefer chiropractors, to be honest. I think we're better at the manual therapy part, but evidence-based care from a qualified professional is what I think is important for patients. The alternative for elderly people, if they know they have a degenerative condition that may need surgery, some of them, what do? They just shut it down. I'm not going to exercise. Oh, it hurts. I don't want to do it. You have to keep these people going. And one thing that Carlo's program has done to great benefit of many patients, I think, is push them to move and make sure that their bodies are strong, stable, and as fit as possible, regardless of whether their symptoms are improving or if they need to consult a surgeon. And also, to put your mind at ease, surgery is necessary in some patients. About 1 in 3 are going to at least need to speak to a surgeon, but they still need our help before and after the surgery if the surgery is the ultimate outcome that they need. So that's the talk on spinal stenosis. Look at that timing. We're right at 12:59. I'm going to highlight this next webinar. As I said earlier, I'm skipping May as a month, partly because I have a four trip travel schedule for speaking and presenting, including 2 jaunts over to Europe. So in June, on Thursday, June 19th, my friend and colleague, Dr. Demetrios Simakopoulos, will be joining me, and we're going to do a tandem webinar featuring 7 ways to enhance patient outcomes for your chronic pain patients. I know many of you on the call today or watching this afterwards have already signed up for this one. If you haven't and you're interested, I would sign up soon. At the time of this recording, the tickets are 25% off anyway, but why I'm saying this is I think this one's going to sell out. I have a certain capacity on my Zoom for a certain number of people, so I think this one's going to sell out. Then I'm going to take a break for the summer and come back with, I think, a series of 9 webinars next year. As I said, many of you have been on all of them so far, and I think what I might do is make a package where you're just automatically on all of them for the year and get the recordings and sell that as like a single product. But I'll figure that out over the summertime. Again, if you have any suggestions for topics, please let me know. If you're interested in a deeper dive in healthy aging, I do have an online 8-hour program called Older and Bolder Chiropractic Care for Healthy Aging, where we go through all the literature relating to chiropractic care of elderly patients and condition-specific things like degenerative cervical myelopathy, lumbar spinal stenosis, which we covered today. There's more detail in that program. Osteoarthritis, we do a deep dive in that program as well. It's been one of my best-selling programs. Again, it's on for 25% off at the time of this recording. And with that, I will thank you for your time and attention. And please contact me if you have any suggestions or feedback. And if any of you would like to stick around and ask some questions or chat about anything, I'm happy to stick around. But for the rest of you, I'll end this recording. Thank you for your time. And if for everything that I do, you know where to find me, and you can find our courses and webinars at seanthistle.com. Thank you, everybody.